We'll continue our discussion regarding liver function. So next we are going to discuss the different tests or different laboratory liver function test. Okay, so assessment of liver function or liver function test. Okay, so the first liver function test, it is bilirubin, and the principle for the determination of bilirubin is diazo reaction. So meaning it's the reaction between the diazotized sulfonilic acid, that is your diazo reagent, and bilirubin, which is present in the specimen, and you have a colored product, okay, that absorbs light. Then you have two methods. You have Evelyn and Malloy and Jindrasik and Groff. So the difference is the use of methanol as accelerator in Evelyn and Malloy. And for Jindrasik and Groff, you have caffeine benzoate acetate, or caffeine sodium benzoate, the accelerator. So the purpose of accelerator is for B1, okay? Uh, B1 to react with the diazo reagent, because without the addition of accelerator, B1 cannot react with the diazo reagent uh, to form azobilirubin, or to form the colored product. Okay. So next, in the laboratory, we're measuring the total bilirubin and direct bilirubin. So to measure total bilirubin, you need your serum specimen plus diazo reagent and the accelerator, okay, to get the total bilirubin. And for direct bilirubin, you have serum plus diazo reagent, and no need to add um, the accelerator, because we want to measure the direct bilirubin. Okay, so the characteristic of direct bilirubin, it is capable of reacting with diazo reagent without the use of the accelerator. Okay, so we have your direct bilirubin concentration. So to get the concentration of indirect bilirubin, which is the majority, okay, of your total bilirubin, the formula is total bilirubin minus direct bilirubin. That is the concentration of your indirect bilirubin. Okay. Then next is the characteristic or other names of your bilirubin. Bilirubin 1 and bilirubin 2. So unconjugated bilirubin, this is your B1, and it is non-polar, water insoluble, correction, this is water insoluble, and bound to albumin. And it will react with the reagent in the presence of the accelerator. So for you to measure, or for you to allow, okay, um, bilirubin 1 to react with the azo reagent, then you need to add accelerator. It's either methanol or caffeine benzoate. Then next is the conjugated bilirubin, or B2. So it is polar, direct, because it will directly react with the diazo reagent. And it is water soluble. So unconjugated is water insoluble. This one is water soluble and not bound to any protein. So react with the reagent even in the absence of the accelerator. Okay. Next is the third type of bilirubin. It is delta bilirubin. So delta bilirubin is more of a hybrid of B1 and B2, because delta bilirubin is a conjugated bilirubin bound to albumin. So this one is a characteristic of B1 and B2. Okay, so hybrid. So it is seen in hepatic obstruction or biliary obstruction. That's the indication of delta bilirubin. And same with conjugated bilirubin, it will react directly with the uh, diazo reagent. Okay. Next is the specimen collection for bilirubin. So for specimen collection, serum and plasma are acceptable specimen for bilirubin measurement. Okay. Now, if we're going to use Evelyn and Malloy as the method, then you need to use serum. You're not allowed to use plasma, because there's a tendency that the methanol used in Evelyn and Malloy will cause precipitation with the fibrinogen present in plasma specimen. So that's why um, in Evelyn and Malloy, the preferred or the acceptable specimen, it is serum, because for plasma contains fibrinogen, and that fibrinogen uh, possible nga there will be a precipitation reaction between the methanol that you're using as the accelerator and the uh, fibrinogen present in plasma specimen. Okay, so for Evelyn and Malloy, the preferred specimen, it is serum. Okay, but for Jendrasic and Groff, you can use either plasma or serum. Okay, the next is regarding fasting. Fasting sample is the preferred specimen because lipemia increases bilirubin concentration. Okay, fasting is the preferred specimen because lipemia increases bilirubin concentration. So regarding lipemic sample, the usual cause of lipemic sample is the presence of chylomicrons, which carries triglyceride, exogenous triglyceride. Now, characteristic of chylomicrons, it is usually cleared from your plasma 6 to 9 hours postprandial or 6 to 9 hours after eating. Okay, so the preferred specimen for bilirubin, it is fasting, but usually in the laboratory setting, uh, most of the institutions, they do not require fasting for bilirubin as long as the specimen is not lipemic. Okay, so regarding lipemia, it increases bilirubin concentration. Now, regarding this point in the reviewer by Ma'am Rodriguez, it is stated there nga the effect of lipemia is false decrease, but in Bishop, it is false increase. So I need to follow the uh, points pointed out by uh, Bishop, okay, because that's our reference book. And if we are going to analyze it, lipemic meaning turbid. So if we're going to differentiate the absorbance of a turbid solution and a clear solution, the turbid solution will have the higher absorbance reading. And remember, absorbance is directly proportional to the concentration. Okay. Next is avoid hemolyzed specimen because it decreases reaction with diazo reagent. And the sample should be protected from light because bilirubin is a photosensitive analyte. So the expected decrease in bilirubin concentration if there is light exposure, it's 30 to 50% decrease per hour. And is stable for 2 days at room temperature and 1 week at 4 degrees Celsius and indefinitely at negative 20 degrees Celsius. Okay, so those are the specimen consideration for bilirubin measurement. So next you have the method, the candidate reference method is the Jendrasic and Groff, okay, because it's not affected by pH changes, insensitive to a 50-fold variation in protein concentration of the sample, so no precipitation to happen. Next, maintains optical sensitivity even at low bilirubin concentration and not affected by hemoglobin up to 750 mg per dl. The next is you have two methods, Evelyn and Malloy and Jendrasic and Groff. Okay, same procedure, same reagent. The difference is the nanometers, okay, the wavelength, and the accelerator. Okay, and regarding the azobilirubin color, it's red purple for Evelyn and Malloy. It's purple for Jendrasic and Groff. But if you're going to add alkaline tartrate in Jendrasic and Groff, the end color will be blue. Okay. The next is you have Eurobilinogen in urine and feces. So for Eurobilinogen and in urine and feces, this is another Eurobilinogen is another liver function test. Okay. So regarding Eurobilinogen, it is a colorless end product of bilirubin metabolism oxidized by intestinal bacteria to urobilin. Now, regarding diseases associated with increase in urine urobilinogen, first is hemolytic disease. Now, in hemolytic disease, first, diba, hemolytic anemia. So, meaning increased destruction of red blood cells. Since there is increased destruction of red blood cells, next is you have increased release of hemoglobin from the destroyed red blood cell or damaged RBC. So you have increased hemoglobin. Okay. So increased hemoglobin. Next is you need to convert, or there's a need to convert the excess or to convert heme to bilirubin 1. Okay, so meaning there's also increase in bilirubin 1. That's one of the characteristics of prehepatic jaundice. And the common cause of prehepatic jaundice is hemolytic anemia. Okay, so since the liver is functioning properly, the B1 will be converted to B2. So meaning there is increased concentration of B2 that will appear or will be present in the intestine. Okay. Now, regarding urobilinogen, it is formed by uh, oxidation of bilirubin to urobilinogen by bacteria. Okay, so next is the conversion of increased concentration of B2 to increased concentration of urobilinogen. Then 20% of urobilinogen will be reabsorbed by the body and it will be excreted via urine and or the second one is to reprocess urobilinogen via liver. So the effect, you have increased urobilinogen in urine. That's for hemolytic disease. Next is defective liver cell function. So for defective liver cell function, after the absorption of the 20% of urobilinogen, the next process or the next step is to reprocess urobilinogen in the liver. But the problem is the liver is not able to reprocess urobilinogen because there's a problem with or there's a defect in the liver cell function. So the only way na karon sa body to eliminate urobilinogen is via urine. That's why the concentration of urobilinogen in liver cell defective liver cell function is increased because uh, in a normal condition, you have two ways to eliminate absorb urobilinogen. So first is via reprocessing of urobilinogen in the liver, and second is via excretion of urobilinogen in the urine. The problem is in defective liver cell function, the liver cannot process the absorb urobilinogen. So the only way to eliminate that one is via urine excretion, okay, or excretion via urine, okay. So the effect, you have increase in urine urobilinogen, okay. Next is the absence of urobilinogen or decrease in urobilinogen, urine urobilinogen. And it is seen in biliary obstruction because in biliary obstruction, you have obstruction in the bile flow. Now remember, regarding bile, the major pigment of bile, it is bilirubin. So decreased bile flow, decreased excretion of bilirubin 2. So decreased excretion of bilirubin 2, decreased formation of urobilinogen. Decreased formation of urobilinogen, decreased absorption of urobilinogen. Okay? So that's why you have decrease or absence of urobilinogen in the urine specimen. Okay? Next, regarding the three conditions, hemolytic anemia, liver disease, and biliary obstruction, the urine bilirubin for hemolytic anemia is negative because in hemolytic anemia, the bilirubin, type of bilirubin that is elevated, it is B1. And remember, B1 is unconjugated and it is bound to albumin. So it is not seen in urine specimen. Okay. For liver disease, it is positive due to the increase in B2. Okay, positive urine bilirubin due to B2 or conjugated bilirubin. Same with biliary obstruction, positive due to B2. Okay. Then for urine urobilinogen, for hemolytic anemia, it is increased, liver disease increase, and for biliary obstruction, it is normal. Because normal siya because the urine strip or chemical urinalysis strip cannot determine the absence of urobilinogen. That is the limitation of the chemical urinalysis strip. It cannot detect the absence of urobilinogen. So the uh, lowest reading or reporting, it is normal. Okay. So in Multisticks is a brand that produces chemical urinalysis strip. So in chemical urinalysis strip, the principle of the determination of Eurobilinogen is Ehrlich's reaction. So you have the reaction of Eurobilinogen plus p-dimethylaminobenzylaldehyde. Then you have light to dark pink color end product. Okay. The disadvantage or limitation of Multisticks and other brand for chemical urinalysis strip is the inability of the reagent strip to determine the absence of urine urobilinogen. So specimen to our urine specimen, it should be fresh, and tests must be performed without delay to prevent oxidation of urobilinogen. Okay. Next liver function. So the first liver function, you have bilirubin. Second is urobilinogen. And third, you have the liver enzymes. So for liver enzymes, you have ALT or your alanine aminotransferase. AST, that is your aspartate aminotransferase. ALP is your alkaline phosphatase. LD is or LDH is lactate dehydrogenase. GGT, that is your gamma glutamyl transferase, and 5-nucleotidase. So for aminotransferase, highest elevations are found in acute conditions such as viral hepatitis, drug and toxin-induced liver necrosis, and moderate elevation in obstructive jaundice. Okay. So regarding ALT and ALT and AST, these transaminases or transferases are usually significantly increased in hepatocellular injury. Okay, but these transaminases are slightly elevated in hepatobiliary. Okay, meaning of hepatobiliary more on the bile flow. Hepatocellular more on damage to the hepatocyte. Okay. So next, phosphatase. So for phosphatase, example, you have your ALP, which is located in, or one of the sources is the bile canaliculi. And it is a marker of extrahepatic biliary obstruction. And there is very high concentration of ALP in extrahepatic obstruction and slight elevation in hepatocellular disorder. Okay, so for ALP, there is slight elevation in hepatocellular disease or hepatocellular injury, and significant increase if there is hepatobiliary obstruction. Okay, meaning ALP is more of hepatobiliary, and then ALT and AS is more of hepatocellular. Okay. The next is 5-nucleotidase. So 5-nucleotidase, it is a phosphatase and it has no bone source, and it is useful in differentiating ALP elevations. Now, regarding alkaline phos, okay, ALP, the two most common cause of increase in total ALP, okay, is you have obstructive jaundice or biliary tract obstruction and bone disorder. Okay, so remember, if we talk about ALP, you have four major sources of ALP. You have liver, bone, placenta, and the intestine. But regarding the predominant isoenzymes of of alkaline phosphatase, you have liver and bone. Meaning, if there's increase in ALP, you have two possible causes. You have obstructive jaundice or biliary tract obstruction, and second is bone disorder. Okay? Now, to differentiate the increase in ALP, you need to run 5-nucleotidase. So, balik ko na, increased total ALP, it's seen in obstructive jaundice and bone disorder. So, to differentiate the increase in ALP, you need to measure 5-nucleotidase. Because 5-nucleotidase is increase in obstructive jaundice and normal in bone disorder. Okay, so that's for 5-nucleotidase. Another way of differentiating increase in ALP is via using GGT. So GGT is gamma glutamyl transferase. So this is also increase in obstructive jaundice and normal in bone disorder. Okay, so it plays a role in differentiating the cause of elevated levels of ALP. Substances that cause increased GGT have alcohol, barbiturates, tricyclic antidepressant, and anticonvulsant. So regarding alcohol, GGT is used to detect occult alcoholism or hidden alcoholism. Okay, so if you ingest alcohol, automatic there is increase in GGT concentration, and that increase in GGT concentration will go back to normal once um, once will go back to normal within 2 to 3 weeks. Okay, if uh, you abstain from drinking alcohol within that period, 2 to 3 weeks. Okay, but if every day ka nag drink, then there is continuous increase in your GGT. Okay. Next is lactate dehydrogenase. So for lactate dehydrogenase, it is non-specific marker of cellular injury because it has a wide tissue distribution. Okay. And there is moderate elevation in LD in hepatitis and cirrhosis, moderate elevation in hepatitis and cirrhosis, and slight elevation in obstructive jaundice, and significantly high concentration of LD in metastatic carcinoma. Now, the problem with lactate dehydrogenase, it's not specific, so you need fractionation of LD or lactate dehydrogenase into its 5 tissue-specific isoenzyme, and that may give you useful information about the site of origin of the LD elevation. Okay, so we have 5 isoenzymes of lactate dehydrogenase. You have LD1, LD2, LD3, LD4, and LD5. The most abundant is LD2. Okay, so we have 1, 2, 3, 4, and 5. So regarding most abundant, it is 2. So in a normal pattern, you have LD1 less than LD2. Okay. Now the main source of 1, it is the cardiac tissue, kidney, and RBC. So for example, if there is AMI, acute myocardial infarction, the LD1 concentration will be greater than the concentration of LD2. So this one is what you call flip pattern. Okay, so flip pattern is an indication that there is acute myocardial infarction. Okay, next, regarding LD3, it is found usually in the lungs, and if there's a problem with your lungs, LD3 is usually increased. Then 4 and 5, more of skeletal muscle and liver. So in order to increase the use of lactate dehydrogenase, there is a need to do fractionation, meaning to separate the different isoenzymes of lactate dehydrogenase. Next is test measuring hepatic synthetic ability. So to measure hepatic synthetic ability, you need to measure total serum protein. It is not sensitive to minimal liver damage, but in severe liver damage, the concentration of albumin is low and also the total protein, because liver is responsible for the production of proteins except immunoglobulin and your adult hemoglobin. Okay? So that's for total serum, no, for your liver and total serum protein. So if there is a problem with your liver, usually the concentration of your total protein or total serum protein is decreased. Okay? Now, another reason why or what is the clinical significance of total serum protein test? So for total serum protein test, it is used to assess nutritional status, okay, and the presence of severe diseases involving the liver, bone, and kidney, okay. So involving the liver, kidney, and bone marrow, okay. So for example, in liver failure, you have decreased total protein concentration. Why? Because of decrease in the production of proteins. In kidney disease or kidney failure, you have decreased total protein due to increased excretion of proteins. And in bone marrow, okay, example, you have multiple myeloma. Okay, so in multiple myeloma, you have excessive production of IgG. Okay, so the effect, you have increase in total protein concentration. Okay, so the clinical significance of your total protein test or total serum protein test is to assess nutritional status and the presence of severe diseases involving the liver, kidney, and bone marrow. Okay, next is prothrombin time, another liver function test. So prothrombin time increase, it indicates the severe diffuse liver disease and poor prognosis. And it is due to low clotting factors. Disruption in the bile flow, you have low vitamin K absorption. Okay. Now in prothrombin time, it is a part of your coagulation studies. And in clinical chemistry, if we're going to correlate uh, prothrombin time in clinical chemistry, there are two causes of increase in prothrombin time. So first is uh, what you call this? First is you have liver disease or hepatocyte injury. Okay, and second, you have obstructive jaundice or biliary obstruction. Okay. So in liver disease or hepatocyte injury, you have decrease in the production of clotting factors. That's why the prothrombin time is increased because liver is responsible for the production of clotting factors. Okay. Now in obstructive jaundice, the reason why there's an increase in prothrombin time, it's because of decrease in bile flow because bile is important in the absorption of vitamin K. So in biliary obstruction or obstructive jaundice, you have decreased vitamin K or vitamin K deficiency due to decreased vitamin K absorption. Why man there is uh, uh, vitamin K deficiency? It's because of, or why man decrease ang absorption of vitamin K? It's because of decreased bile flow because you need bile to absorb vitamin K. Okay? So these are the two causes of increased prothrombin time. Now, next is how to differentiate increase in prothrombin time. So you need to perform vitamin K response test. Okay, vitamin K response test. Now, what is the use of vitamin K response test or how to perform vitamin K response test? Then you need to administer 10 mg of vitamin K via IV daily for 1 to 3 days. Okay. So after the administration of vitamin K, after 3 days, then you need to check again the prothrombin time. So you need to measure prothrombin time before and after vitamin K administration. Now, in liver disease or hepatic injury or hepatocyte injury, after the administration of um, after after the administration of vitamin K, if there's hepatocyte injury, the prothrombin time is still the same. It is increased. Okay, because the problem in hepatocyte injury is the decrease in clotting factors, not vitamin K. Okay, so if you administer vitamin K, it's useless because the clotting factors are absent. Okay, so the prothrombin time is still the same. It is increased. Now, in obstructive jaundice, since the patient has vitamin K deficiency due to decreased absorption of vitamin K, and that's due to decreased bile flow. So there is vitamin K deficiency. Now, next is you administered vitamin K. So after vitamin K administration, the prothrombin time is decreased or meaning there is improvement in prothrombin time. Okay, so for example, before vitamin K administration, the prothrombin time is 10. Then after administration of vitamin K, the prothrombin time is 1. Okay, so there's a decrease in prothrombin time. So example lang na ha, it's not the correct values for prothrombin time. Okay, just an example. So decrease prothrombin time after vitamin K administration, that is obstructive jaundice. If same, increase, then that is hepatocyte injury or liver disease. There's liver disease, hepatitis. Okay. Then next, last, you have test measuring nitrogen balance. So liver, this is liver, is important in the removal of ammonia. So ammonia is toxic. Okay. Since toxic, the liver must convert ammonia to urea. Okay. So in liver failure, the concentration of ammonia is increased due to the inability of the body to convert, or the inability of the liver to convert ammonia to urea. So there's accumulation of ammonia and other waste product, and it can cause hepatic coma. So regarding ammonia, it's toxic and can cause damage to your brain. Specimen for ammonia, you can use EDTA, heparin, and potassium oxalate as anticoagulant in the collection of specimen. The preferred specimen is arterial blood. Okay, the alternative is venous blood, but you're not allowed to use tourniquet in the collection of venous blood for ammonia. Why? Because the use of tourniquet can cause false increase in ammonia concentration. Then next is place the sample on ice to prevent metabolism, or to prevent further deamination. Okay, because the effect of not putting or uh, putting your sample in a slurry of ice water can cause further deamination, and the effect of that is false increase in your ammonia, because ammonia is a product of deamination of amino acid. Next, if analysis cannot be performed immediately, the plasma should be removed and placed on ice or frozen. Reject hemolyzed specimen because it can cause false increase in ammonia due to the presence of ammonia inside the red blood cell. Then usually if there's increase in GGT, the concentration of ammonia is also increased. And reject lipemic sample because it will give you erroneous result regarding your ammonia concentration. Okay, so that's all regarding liver function. Okay, so next meeting we'll have a quiz regarding this discussion.